All right, we're going to go ahead and continue. And you discussed a little bit about, the stigma coming forth to discuss behavioral health concerns or mental health concerns a soldier may have. Are there anything that you want to elaborate on to
Right.
kind of break down that
When
stigma?
people are referred to me, one of the things that we do, or that I do particularly, is to be very honest about why they're coming to see me, what I can do, what I can't do, and what the limits of confidentiality are. The other piece is to make sure I destigmatize or not pathologize every issue. Life happens to us all. It's when it crosses that line to where somebody becomes suicidal or wants to die that it becomes a disorder. People becoming sad over the death of a loved one, or having PTSD symptoms, or having difficulty sleeping might be normal reactions. When it crosses that line to they want to die, then we have an issue. So we want to make sure that we let people know that everybody has stuff, and normalize their emotions and their feelings, and normalize that it's okay to get help.
Okay. What types of healthcare professionals do you routinely work with, and how do you strengthen some of those relationships that you have with them?
I work really closely with the state family counselors that are LPCs, or clinical social workers, licensed professional counselors and clinical social workers. And with them, it's a lot of getting to know each other and understanding what our lanes are, where I can help and where they can help, and making sure that we're really clear on the different roles and not becoming territorial. I work with medical command, the case managers, and again, my role there is to build those relationships, get to know them, and also identify how we can work together to supplement what's already being done, not become territorial. The medical readiness NCOs and the medics have a different understanding of the soldiers than other people do. So again, it's getting to know the individuals and pulling in the team approach that there's plenty of work for all of us. And how do we facilitate care versus try to do what another person's doing.
And what is it that you enjoy the most in your line of work?
Oh, I love taking care of these kids, these soldiers. Just taking care of soldiers is the best thing that I do every day apart from going home. I don't know how to quantify why I like taking care of soldiers. I've been trying to do this for 30 years, and at 50 years old, I get to do the work I love doing. What I'm seeing in this job, different than a lot of other jobs, is we're seeing the success stories. We're seeing the people that had been suicidal, that got help, and are doing better. We see the person with a severe substance abuse problem that is initially resistant to treatment, that finally engages us in treatment, and finally says, oh, I'm not going to stop now. And to see the success of the units becoming more effective, those are the perks I never... The other part too is I work with people, when I was a civilian, we worked with people. We worked with coworkers. In the Army, we served together, and I'm finding that dynamic of serving with people is different than just working with them.
And where do you believe some opportunities may lie for improvement in the organization or within your lane of work?
Looking at the better use of behavioral health providers and looking at the better use of serving the state. I think that the behavioral health officers have to be used as an in-garrison asset as well as a mobilized asset. When we have over 200 services with active permanent profiles, and probably 500 to 600 people with current behavioral health profiles that have never seen a behavioral health officer, I think that that's too high. I think that there's a better way to use this with the full medical readiness events, that we're doing a better job of screening and following up, and a better job of engagement.
Okay. And what do you see on the horizon, whether it be good or bad, and how do the relationships you currently have shape what is to come on the horizon for behavioral health?
I think as we get better known, the state OSARS program has been in existence for 1 year. As we get better known, I think the referrals will increase. I think the outreach, I think as people get to know what we are and we start having more of these successes, I think our numbers will go to between Right now, we're about 1% of the total force that are considered moderate to high risk. I think that number will go to between 3 and 5%. I think it'll cause us to be on our toes a little bit more and have a better use of the mental health techs, of the current behavioral health officers, and of the medical service officers in identifying how we meet these needs and maintain a ready force.
And do you have any final thoughts that you would like to convey?
The 6 suicides in Texas military forces in the last year is a significant concern. It's 3 times the state population of suicides. I don't think we can sit any longer and accept any excuses. I think as a military, we have to, and as behavioral health officers, we have to take responsibility for finding out where the gaps are and finding a way to overcome barriers. I think we have to be solution focused and outcome focused versus output focused.
All right, thank you. That concludes the interview questions.